Today we will cover an important topic on head injury assessment, which is Glasgow Coma scale. This is one scale which every student, every doctor, every person working in emergency department or for that matter in any hospital should know. Before we go into details of evaluation in terms of Glasgow Coma scale, we must know why Glasgow Coma scale is important. It's an objective assessment of a patient of head injury. There is no confusion when a person is communicating a patient's score in terms of GCS. A drowsy patient, conscious patients, these are the terms which are confusing. But once a patient is scored based on GCS, it's an objective assessment. The score cannot change. It is very easily communicated to the treating team, between the treating teams, from one doctor to another, from one student to another. It helps in making decisions. If a patient is having worsening GCS, then it has to be correlated clinically, radiologically. If necessary, we may have to increase some drugs in form of mannitol, Lasix, decongestants, antiepileptics. We may have to look for some electrolyte disturbances. We may even have to think of operating the patient in view of a worsening GCS. Of course, there is a reliable reporting when a person is reporting the patient's condition based on GCS, and it does help medico-legally in court of law. In this video, we will understand GCS based on following 5 factors. What is GCS and definition, grading of the head injury, how to check for GCS, how to score, and what are the special conditions where GCS may be erroneously misleading. So coming to first point, what is Glasgow Coma scale? It's a scale for assessment of head injury in terms of eye, verbal and motor best response. The total score varies from 3 to 15. Patients of head injury are graded into mild, moderate and severe depending on GCS score. A score of 8 or less qualifies the patient as comatose, whereas a minor head injury is a score of 13 to 15. For scoring GCS in a patient of head injury, a good amount of pain is to be given in either of the trapezius region, that is shoulder region, or in the supraorbital region, or a strong pain stimulus on a sternal region, or even in upper extremities, fingertips. Pain given in lower extremities will not help in scoring of GCS. So coming to details of how to evaluate a patient in terms of GCS. The first important part is response of patients in terms of eye opening. If the patient is able to open eyes on his own spontaneously and is looking around, then the score of 4 is given. If patient does not open eyes spontaneously but opens when talked with, then the score is 3. If the patient opens the eyes only on a painful stimulus, the score is 2. And even after a painful stimulus, if the patient is not opening eyes, the score is 1. As told earlier, there is no score 0 in GCS. Next important component of GCS is verbal response. Here patient is scored from 5 to 1 depending on his response to the questions. Patient is asked questions regarding time, place and person. If he is answering all the questions correctly, then the score of 5, or a oriented patient is there, and we give a score of 5. If the patient is able to understand the question but he is not answering correctly, then the score is 4, or disoriented patient. Here, if for example, if we ask what is the current year and if patient gives wrong year as the answer, then he is disoriented. So patient is able to understand the question but he is giving wrong answers. Next is inappropriate response. Here patient is not able to understand the question and he is speaking on his own. Whatever he wants to speak, he is speaking. You ask the year and he is speaking his name, he is speaking his address, he is asking for food or anything else. So here score will be 3, or inappropriate response. So difference between disoriented and inappropriate is what a patient is able to understand the question, gives wrong answer, it is disoriented. Patient is not able to understand the question, speaks on his own, it is inappropriate. If a patient is speaking but we are not able to understand anything out of whatever is coming out of his mouth, then the score of 2 is given, where the speech is incomprehensible. And if patient is not able to make any sound, then again the score will be 1. Next component of GCS scoring is a motor response. Here the score is given from 6, 5, 4, 3, 2 and 1. A score of 6 is given if the patient is following all our commands like flexion of extremities, gripping and gripping, showing his tongue on command. So if he is obeying all the commands, then the score is 6. If a patient is not obeying command but he is able to localize the pain and he is trying to move away the painful stimulus, then the score is 5. Means if we give the pain stimulus in on trapezius or sternal region and patient is trying to remove our hand which is giving pain, then the score of 5 will be given. In contrast to localization of pain, if patient is not able to localize the pain but is withdrawing to the pain, then the score is 4. Here patient will not be able to understand from where is the painful stimulus coming and he will just start moving his extremities away from the painful stimulus. That is withdrawal response to the pain, and score will be 4. So the difference between score of 5 and 4 is this, that in a score of 5 patient is able to localize the pain and he is trying to move the painful stimulus away. And in a score of 4, patient is not able to localize the pain but he is withdrawing to the pain. He is moving away from the painful stimulus. Next important attribute in motor response is a score of 3 and score of 2, that is abnormal flexion or decorticate rigidity and abnormal extension or decerebrate rigidity. These scores are important because they indicate damage to the brainstem. Whereas a score of 3, there is abnormal flexion in the upper extremities, adduction of the arms and flexion at elbows, and lower limbs are extended. So this is abnormal flexion, score of 3, and it indicates upper midbrain injury. In a score of 2, when we call patient is M2, there is abnormal extension of the elbows and upper extremities and lower limbs are extended. So this is M2 or decerebrate, and here the injury is at the upper pontine level. It is very important to be able to differentiate between M2, M3 and M4 because it will change the decision making process. And if there is no response to pain at all, then the score is 1. This is a graphical representation of M2 and M3 response. The upper image shows M3 response or decorticate rigidity, where the upper limbs are seen to be abnormally flexed at elbow and at wrist joint and the arms are adducted. And the lower picture shows decerebrate rigidity or M2 response, where the upper limbs are abnormally extended at the elbow joint. Though the wrist joint is flexed, arms are adducted and pronated forearms. Lower limbs are extended in both the cases. So this is all about scoring in a GCS, where I score of 4, verbal of 5 and motor of 6 is the maximum score. There are some special factors which we need to consider while assessing GCS. If a patient is intubated, then we may not be able to elicit a verbal response, and so symbol of T is added in the scoring system, VT. Patient can be drowsy or sedated because of drugs given for seizures or for intubation. Patients of facial-maxillary injury or long bone injuries, we may not be able to elicit motor response as expected. And in case of children, many times we have to see whether the child is having consolable cry or inconsolable cry to label him as M6 or M5. Thank you for listening. I hope that this video has clarified GCS in detail. If there are any questions or queries, feel free to comment and feel free to ask. Do subscribe our channel for more educational content on brain and spine.